Thank you very much for inviting me today to give this talk. My first presentation is going to be on persistent headache and migraine. And these are my disclosures. So headache is a common and disabling problem. It is one of the commonest symptoms that we see as clinicians, not only in general practice, but obviously in neurology, with 20 to 25% of our referrals being headaches. The prevalence of headache disorder is around 50%. And as you can see here, the range between episodic migraine, tension type headache, and then chronic daily headache. Headache is highly disabling, and migraine is one of the 20 most common causes of years of life lived with a disability. It tends to affect most troublesome in people in the productive years, so late teens to 50s. So estimates of their financial cost to society is extensive, with almost contributing to 25 million lost work or school days every year. Headache is a misdiagnosed and undertreated problem. The American Migraine Prevalence Prevention Study surveyed 120,000 households and found that only 52% of those meeting the criteria for migraine had been diagnosed with migraine, and only 12% of those patients were actually on a preventative treatment for migraine. And really, to ensure that the patients are getting the most effective treatment, needs to make sure they've had the correct diagnosis. And headache disorders have a very large differential, and so it needs to be approached systematically. In order for us to be able to do this, we use the International Classification of Headache Disorders, the ICHD-3, and this gives us a framework to diagnose headache. It splits it into the primary headache syndromes, the secondary headache syndromes, and then the cranial neuralgias. What we then do is kind of look at it from a clinical approach. So it's important to always rule out secondary causes of headache. So looking for things like new onset headaches in those over the age of 50 or 60, sudden onset headaches, associated features such as fevers or systemically being unwell or focal neurological deficits. Once a secondary cause is ruled out, then the diagnosis here is out of a primary headache disorder. And then it's down to us to work out, well, which one is it? And one way of doing that is to split it up into the long-lasting headaches and the short-lasting headaches. Now, within the long-lasting headaches, those which last more than 4 hours, migraine and tension type headaches are the commonest. And then we've also got the new daily persistent headaches, as well as the hemicrania continua. Within the short-lasting headaches, we have the trigeminal autonomic cathalgia groups, which is rare. Cluster headache and paroxysmal hemicrania are probably one of the more common ones that are seen in this group of rare disorders. And then we've also got the other primary headache disorders, such as the stabbing headaches, cough headaches, nummular headaches. And we should never forget, really, medication overuse headaches as well. So in terms of the prevalence of headaches in hypermobile disorders, the literature is sparse, and that's maybe related to the fact that definitions of the various hypermobile disorders is quite variable. And generally, the diagnostic criteria for the ICHD-3 isn't always used. And sometimes the series that we use are very small and poorly controlled. I've listed here 3 studies which have looked at joint hypermobility patients. And I think overall you would agree with me, looking at the results of this, it is pretty clear that patients with joint hypermobility and EDS do have a higher prevalence of migraine compared to control subjects. Now, the causes of headaches disorders in hypermobile syndromes are extensive. There's lots. Within the primary headache syndromes, we've got the migraine, we've got new daily persistent headache, and we've got tension type headaches. We can't forget the orthostatic headaches, and those are the ones which are related to posture, so maybe worse or better whether you're laying down or standing up. And those include the spontaneous intracranial hypotensions, as well as headaches secondary to postural tachycardia syndrome, the POTS. And I believe this will be covered in other talks. We've also got headaches due to structural disorders. These include temporomandibular dysfunction, as well as cervicogenic headaches, the Chiari malformations, trigeminal neuralgias, and cervical artery dissection. Let's start with migraine. So looking at the ICHD-3 diagnostic criteria, generally migraine is defined as episodic attacks of headaches lasting 4 to 72 hours with the following features. Must have at least 2 of the following characterizations: unilateral location, a pulsating quality. Some patients will describe it as throbbing instead of pulsating. Needs to be moderate or severe pain intensity and aggravated by routine physical activity. During the headache, the patients must also describe at least one of the followings, and that includes nausea and/or vomiting. You don't need to have both. Photophobia, so the light sensitivity, and phonophobia, sound sensitivity. Other patients may also describe smell sensitivity by way of osmophobia. We then can further subclassify them based on aura, so whether patients do or do not have auras, and then again on the frequency of the headache. So 15 days or more a month of headache would fulfill the criteria for chronic migraine, whilst 15 days or less of headaches would be episodic migraine. And as you can see, the overall prevalence of migraine is 12 to 15%. And of that group, 0.9 to 2.2% of these patients will fulfill the chronic migraine criteria. So migraine is a polyphasic brain disorder. It is made up of a complex syndrome characterized by headache with specific features and associated symptoms. So you've got the interictal phase. Most patients will then have a premonitory phase, not everybody, but most, and they'll have things like craving, some will find yawning, some will have a heightened perception, some patients describe feeling slightly more on edge, a bit more short-tempered. Some patients will then experience aura. And if they do get aura, the commonest ones will be visual aura, and that can be the visual falsification spectrum. So they'll see zigzags, flashing lights, loss of vision. Some patients also find word finding difficulties and speech difficulties. Numbness is another one by way of sensory aura. And then occasionally patients will also have motor aura. Following this phase, patients will go into the headache phase, and this will be associated with the symptoms that I previously described: the nausea, the vomiting, the light, sound, smell sensitivity, poor concentration, motion sensitivity, so they can't really do very much. They have a much more preference just to lay down and sleep and rest. And once the headache phase has settled, they'll then hit into this postdrome where they're feeling a little bit hungover, don't have much of an appetite, quite tired and exhausted. So in terms of the interictal phase, there's lots of kind of factors that can be involved, including a structural, functional, behavioral, as well as environmental factors. And then in terms of the pathophysiology of migraine, well, that's something that we're still not 100% sure on in terms of exactly what the pathogenesis is. That's something that still remains to be determined. There is increasing evidence for the neural basis of migraine, and there is now increasing body of information evidence for the concept of essential neuronal hyperexcitability as a pivotal physiological disturbance predisposing to migraine. The reasons for increased neuronal excitability may be multifactorial. Most recently, abnormalities of calcium channels have been introduced as a potential mechanism for interictal neuronal excitability. It could therefore be hypothesized that genetic abnormalities can result in lower threshold of response to trigger factors. There is also evidence that magnesium is low in migraine as well. We currently conceive of migraine attacks as originating in the brain. Triggers of an attack initiate a depolarizing neuroelectric and metabolic event likened to spreading depolarization. This event activates the headache and associated features of the attack by mechanisms that remain to be determined, but appear to involve either peripheral trigeminovascular or brainstem pathways, or both. Excitability of these cell membranes, perhaps in part genetically determined, is the brain's route of susceptibility to attack. Factors that increase or decrease neuronal excitability constitute the threshold for triggering attacks. In terms of managing migraine, really it is very much a multifaceted approach. Education and support is crucial, as is lifestyle modifications and trigger management. Also involved is psychological and behavioral treatments. These aren't always as easy to kind of come by. And then we have our pharmacological treatments as well as our surgical treatments. In terms of pharmacological treatments, these are split into the acute abortives or the long-term preventative treatments. In terms of acute and abortive treatments, we tend to offer combination therapies. So that will be things like the triptans with a non-steroidal or paracetamol, plus or minus an anti-sickness. In terms of the long-term preventatives, those tend to be offered to patients who are getting 5 or more days a month of migraine. And what we're aiming for is to get them to the optimum dose and for them to be on that dose for at least 3 months to know whether it's working or not before bringing them off. Obviously, if they get side effects, you wean them off and you go on to the next treatment. I hope what you can see here is that we generally do not advise patients go on opioid-based or mixed analgesics. This is a list of the abortive treatments that we have in migraine. As you can see, there are several non-specific treatments, but as a nice kind of exciting thing for the future, there's a lot more specific treatments coming out. So yes, we have the ergot derivatives. We don't tend to use them very much. Triptans are very common, but they aren't without their own side effects. And obviously they're contraindicated in patients with cardiovascular disease. Coming around the corner in the UK, and it's already being used elsewhere in the world, we've got the ditans and the gepants, as well as the neuromodulators. NICE here in the UK has set out some guidelines for the acute management of migraine. And as I previously mentioned, it tends to go towards the offering the combination of treatments, being triptans, with or without a non-steroidal, as well as combining an antiemetics. Again, it raises the contraindication of triptans in those patients with ischemic heart disease, myocardial infarctions, or severe or uncontrolled hypertension. NICE also has guidelines for the prophylactic treatment of migraines, and these include drugs such as topiramate or propranolol, amitriptyline, riboflavin, acupuncture. And then for those patients who fail to respond to at least 3 prior pharmacological agents and who've addressed medication overuse, we then have the option of trying Botox for them. And more recently now, we've got the CGRP monoclonal antibodies, which again in the UK are for patients who've not responded to at least 3 prior treatments. As you can see from this list, there are several preventative options. A lot of them aren't geared or specifically made for migraine. They're antidepressants, blood pressure tablets, and anti-epileptics. There's also the Botox we mentioned. And more recently, we've got those CGRP receptor antagonists and monoclonal antibodies, which have been specifically geared for migraine. We've also got the neuromodulation by way of supraorbital nerve stimulation and occipital nerve stimulations for those patients who are more refractory to treatment. So we've covered a little bit about migraine. What about migraine and hypermobile syndromes? Well, this study looked into the headaches in JHS and in controls. And I hope you can see here that it's very clear that there is a higher percentage of migraine in the joint hypermobility syndromes compared to the controls. They also had a greater mean headache frequency and were more significantly disabled in terms of their MIDAS scores. The migraine presentation in hypermobile syndromes is florid and frequent and is much more disabling compared to the non-hypermobile patients by 3-fold. Medication overuse may be a likely contributor to patients suffering from more migraines. However, this is probably going to be related to the fact that they're using the painkillers for other disorders, such as the chronic musculoskeletal pain. In terms of management of migraine in hypermobile syndromes and in EDS, normally we try and avoid antihypertensives just due to side effects of low blood pressure, feeling lightheaded. And in terms of the acute treatment, it is a challenge. They may not be overusing it for their headaches. They may be needing it for other joint or muscle issues, but we do need to try and address it as much as possible, but at the same time be understanding that it's not always possible to get down to those 10 days a month of painkillers that we try and get them to. So that's migraine. What I'd like to do now is just to move on to tension type headache. And what is the difference between migraine and tension type headache? Well, migraine was featureful. I hope you would agree with me. It was throbbing, it had the nausea, it had the vomiting, it had the light and the sound sensitivity. Tension type is not. Tension type headaches are featureless. And looking at the ICHD criteria, which are listed here, they tend to not have the nausea or the vomiting or the photophobia or the phonophobia. They generally aren't aggravated by movement, and they're not normally throbbing. They're normally mild to moderate. So very different to the migraines. And in terms of tension type in the hypermobile disorder, the overall prevalence is about 40%, and studies haven't really shown an increased prevalence of cases compared to controls. Management of tension type headaches, again, includes abortive treatments, such as simple analgesics. And once again, generally, we avoid combination analgesics, triptans, and opiates. Prevention treatments include amitriptyline, mirtazapine is another one which works very well. And non-pharmacological treatments include acupuncture, cognitive behavioral therapy, relaxation, training as well. And the last of the main headache ones I'm going to be covering today is that of new daily persistent headache. Now, this is rare. The 1-year prevalence is 0.03 to 0.1%. And in terms of the criteria, it is a very clear and distinct onset. Patients will know when their headache started. They will say to you, it started on this date of this month of this year, and it's been there ever since, and it's never gone away. It's there 24/7, and it's got to have been there for more than 3 months. And that is the difference. Rather than going from episodic migraine and gradually increasing in frequency, these patients are daily from the onset. And in terms of the causes, 30% of them are primary, 70% of them are secondary, resulting following CSF pressure disorders, infections, vascular disorders, or even stressful life events. And in terms of investigations, you would do this by way of MRI with contrast if needed, MRVs, lumbar punctures, and then really you're going to be very much guided on the clinical picture. And in terms of management, we tend to manage the primary variant. So a lot of the new daily persistent headaches, when you dig a bit deeper into the phenotype of the headache, would be more consistent with migraine, for example, or maybe more consistent with a tension type headache. So you'll tend to kind of tailor your treatment to the underlying kind of primary variant as such, but they are more difficult to treat medically. So what about new daily persistent headache in hypermobile disorders? Well, there's been 2 studies here which I've listed. The first relates them to the possibility of them having cervical spine hypermobility. Now, we know that the C1 to C3 nerves converge onto the spinal nucleus of the trigeminal nerve, and they can produce the neck pain and the headache that we see. They're part of that pain pathway. So when they looked into assessing patients with joint hypermobility and cervical spine hypermobility, they did find that there were some patients who had both, so whether that is a reason behind it. Another reason may be the pro-inflammatory cytokines. It may be that in patients with joint hypermobility, they've got chronic central nervous system inflammation, and this cytokine production and the persistent glial activation that arises will then kind of give them a bit more of a chance or put them higher risks of getting new daily persistent headache. There's also the comorbid disorders that impact on headache disorders. Anxiety, for example, we know this paper found that 32% of patients with joint hypermobility syndrome had anxiety compared to 12% in control. There's also sleep disorders, including periodic limb movements, which was found in 67% of adults with EDS compared to 8% of controls, and other sleep disturbances such as sleep apnea, restless legs, snoring. All of this can affect sleep and as a result have an impact on migraine and other headache disorders. We've also got the mast cell activation syndromes, and patients with EDS who've got that mast cell activation syndrome or histamine sensitivity, and we know histamine is a potent trigger for migraines. And then not forgetting, as I've already mentioned, the medication overuse headaches, which can wind up migraine and other headache disorders. And this will probably develop through chronic overuse of their acute medication, which is either being used to treat their headaches or their other pain disorders. So why are our primary headache disorders overrepresented in hypermobile syndromes? Well, there's a couple of theories. Is it related to vascular endothelial dysfunction? Are the cerebral vasculature with atheremboli kind of triggering aura phases in these patients? Is it due to dysautonomia? For example, patients with POTS and hypermobility. Is there a pro-inflammatory cytokine effect that we mentioned before, kind of pain that may be due to the chronic central nervous system inflammation and the cytokine production? Or is there a centrally mediated pain neuromatrix dysregulation? Have we got altered neuromodulation of pain in joint hypermobility patients, for example, with fibromyalgia? They may have a lower threshold for primary headache syndromes than other pain syndromes. And then, And then not only is headache a painful disorder, but is also incredibly disabling. Now, according to the World Health Organization and a study they did back in 2013, migraine on its own was found to be the 6th highest cause of years lost due to disability. And headache disorders collectively were the 3rd highest. And this is due to a kind of a recognized burden on sufferers, including loss of personal suffering. It's impairing their quality of life. They get repeated headache attacks. They live in fear of when the next one's going to happen. It doesn't only impact on them, it impacts their family life, their social life, and everything kind of going on around them. And also the long-term effects of a chronic headache disorder may predispose them to other illnesses, such as the anxiety and the depression. And that is seen much more often in patients with migraine than in healthy controls. And when they looked in the United States and in the UK, they realized that only half of those who had been identified with migraine had actually seen a doctor for their headaches within the last year. And only 2/3 of those had been correctly diagnosed. Most people were just overusing painkillers or over-the-counter medications. And really, it's that appropriate treatment of the headache disorders which is so important. And that relies on not only training the healthcare professionals, ensuring patients are accurately diagnosed and recognized, but also ensuring the patients are educated about their headaches and what the options are out there for them. So what are the barriers to effective care? Well, sometimes it's a lack of knowledge among healthcare professionals and providers. We know headache isn't one of the big topics that are taught in undergraduate medical education. And as I mentioned, worldwide, only 40% of those patients with migraine or tension type headaches are professionally diagnosed. It's also making sure that the general public are more aware of this problem. A lot of people kind of don't perceive headaches as being an issue. It doesn't cause death. It's not contagious. So a lot of people aren't really aware of how disabling it is, or of what the treatment options are available that are out there. And there's also kind of the seeking to constrain healthcare costs as well. And I think really if the direct cost of treating headache patients is actually quite small in comparison to the huge indirect cost savings that might be made by reducing the lost working days, especially given that patients who are affected by migraine are during the productive years. So in summary, headaches are common in hypermobile disorders, particularly hypermobile spectrum disorders and Ehlers-Danlos syndrome. There is a large differential diagnosis for headaches in hypermobile disorders. And these patients also have multiple causes potentially for headaches. Clinicians looking after these patients need to carefully assess for the various potential causes of the headaches and make sure that the appropriate management strategies are put in place. Pathophysiology of headaches and non-headache manifestation is often interrelated. And you need to have a multidisciplinary approach, ideally, as it is a multi-system involvement that often impacts on the headaches. And definitely we need much more research to be done regarding the interrelationships between hypermobile disorders, headache, and neck pain, as this may represent a subgroup of patients with different pathogenesis and treatment options. Thank you for listening.